Hello everyone, my name is Dr. Ominda. In this lecture series, I'm going to discuss about the gross anatomy of the colon. And the colon has four parts. You have the ascending colon here, then the transverse colon, descending, and the sigmoid colon. Between the ascending and the transverse, you have a right colic flexure or hepatic flexure. Then transverse and descending, you have a left colic or splenic flexure. So the colon lies to the right of the small intestine first, then superior to the small intestine, then anterior to it, then to the left, and eventually inferior to the small intestine. So we'll start with the ascending colon because it's the first part of the colon. So the ascending colon is the second part of the large intestine after the cecum, and it's located on the right and extends from the cecum to the right lobe of the liver where you have the hepatic flexure or the right colic flexure. The ascending colon is actually narrower than the cecum and is secondarily retroperitoneal. What do we mean by secondarily retroperitoneal? It eventually became retroperitoneal. Initially, it was not retroperitoneal. Then it's along the right side of the posterior abdominal wall, and it's only covered by peritoneum on the anterior and the lateral aspects. It's only covered by peritoneum anteriorly and on its side, and it's separated from the anterolateral abdominal wall by the greater omentum. Usually there's a deep vertical groove on the lateral aspect of the ascending colon. This is what you call the right paracolic gutter, a deep vertical groove on the lateral aspect of the ascending colon and the adjacent abdominal wall. That's the right paracolic gutter. So the blood supply to the ascending colon is by superior mesenteric artery. This superior mesenteric artery gives ileocolic and right colic arteries that go to the ascending colon. These usually anastomose with each other, and they also anastomose with the right branch of the middle colic artery. So superior mesenteric gives ileocolic and right colic that will anastomose with the branch of middle colic artery. So remember, you still have the anastomotic arcades that we saw in the small intestines, but these arcades, you have the arcade of the ileocolic and right colic together with middle colic, left colic, and sigmoid, forming the marginal artery of Drummond, which is the juxtacolic artery. So this is what we mean. We have superior mesenteric artery here. So it gives the ileocolic branch, right colic, okay, and middle colic. So these are coming to anastomose to form this marginal artery of Drummond and then give branches to the ascending colon. Then inferior mesenteric artery gives left colic as well as sigmoid artery that form an arterial arcade and join the remaining half of the marginal artery of Drummond. So basically the colon is supplied by marginal artery of Drummond, and this marginal artery of Drummond is formed by branches of superior mesenteric and inferior mesenteric artery forming an arterial arcade that anastomose. So it's an anastomosis of superior and inferior mesenteric artery branches. Superior mesenteric gives ileocolic, right colic, and middle colic to the ascending colon and part of the transverse colon. Then inferior mesenteric will give left colic to the descending colon and the splenic flexure, and sigmoidal artery to the sigmoid colon. So this marginal artery of Drummond parallels and extends the length of the colon close to its mesenteric border. So it's at the, remember there's the mesentery at these vessels are on the mesentery. Okay, so this is the mesenteric border, this is the anti-mesenteric that does not have the mesentery attaching onto it. So this is anti-mesenteric border and this is the mesenteric border. So the vessels are on the mesentery. So the mesenteric border gets more nutrition and oxygen, more blood supply than the anti-mesenteric border. So therefore, the anti-mesenteric border usually has low blood supply. So the anti-mesenteric border is a watershed area of the colon. So what is the venous drainage of the ascending colon? The ascending colon, the veins will correspond to the arteries. So you have the ileocolic vein and the middle colic vein as well as right colic. So it's mainly ileocolic and right colic Then the middle colic gets mainly to the hepatic flexure and the transverse colon. So all these will drain to the superior mesenteric vein that later joins splenic vein to form portal vein. Lymphatic drainage of the ascending colon is by epiploic and paracolic lymph nodes. Okay, these epiploic and paracolic lymph nodes will later drain onto superior mesenteric lymph nodes. These are lymph nodes around the origin of superior mesenteric artery. The ascending colon is innervated by sympathetic and parasympathetic nerve plexus following the superior mesenteric artery. So we call them superior mesenteric nerve plexuses. From ascending colon, we get to the transverse colon. Transverse colon is 45 centimeters long, so it's the longest part of the colon. It's the third part of the large intestine. Remember, first part is cecum, then ascending colon, then now the transverse colon. The transverse colon is the most mobile part of the large intestine. It usually crosses the abdomen from the right colic flexure to the left colic flexure. So the transverse colon is from the right colic flexure to the left colic flexure, and it bends inferiorly, forming the descending colon after the left colic flexure. So the left colic flexure is also called the splenic flexure, and it's usually more superior than the right colic flexure. It forms a more acute angle and it's less mobile. So those are the differences between right and left colic flexure. The left colic flexure is more superior, more acute, and less mobile than the right colic flexure. It's also anterior to the inferior part of the left kidney and attaches to the diaphragm through the phrenicocholic ligament. The left colic flexure attaches to the diaphragm through phrenicocholic ligament. The transverse mesocolon is a mesentery of the transverse colon. Usually, it loops downwards, inferior to the level of the iliac crest, and is adherent or fused to the posterior wall of the omental bursa. Go back to the lecture on peritoneum and find out what omental bursa is. So the transverse mesocolon is adherent to or fused to the posterior wall of the omental bursa, and its root lies along the inferior border of the pancreas. So the root of the transverse mesocolon is along the inferior border of the pancreas and is continuous with the parietal peritoneum posteriorly. What is the position of the transverse colon? It's variable because it has this transverse mesocolon that makes it hang. It can even hang up to the level of the umbilicus, and in tall and thin people, it may extend downwards into the pelvis. So the transverse colon is variable due to its mobility. What makes it to be the most mobile part? Because of the mesocolon, the transverse mesocolon that it has. So we have the arterial supply of the transverse colon mainly by middle colic artery from superior mesenteric artery. So the transverse colon is mainly by the middle colic artery joining the marginal artery of Drummond. Remember, we said ascending colon is by the ileocolic and right colic. Transverse is mainly by middle colic. So from right flexure to splenic flexure is by middle colic joining to the Drummond artery where you have the arcades onto the transverse colon. So there is a communication between the right colic and left colic arteries with the middle colic arteries, and that's shown here. This is your right colic artery, and this is left colic artery from inferior mesenteric artery. So they will all go and communicate with the middle colic at the marginal artery of Drummond. So what is the lymphatic drainage of the transverse colon? The venous drainage is by superior mesenteric vein because middle colic artery will correspond with middle colic vein, and this middle colic vein gets to superior mesenteric vein that will be joined by splenic vein to form the portal vein that enters the liver through the porta hepatis. The lymphatic drainage, so you have middle colic lymph nodes following middle colic artery that will take the lymphatics to the superior mesenteric lymph nodes around superior mesenteric artery. Again, you have sympathetic and parasympathetic nerves following superior mesenteric artery to form a periarterial plexuses that will get to the transverse colon. These periarterial plexuses will follow the right and middle colic artery and be transferred to the transverse colon. So this just shows you the blood supply of middle colic joins the marginal artery of Drummond to supply the transverse colon, and there's communication with the left colic from inferior mesenteric and right colic from the superior mesenteric. Then we go to the descending colon. This occupies a secondarily retroperitoneal position. Descending colon is retroperitoneal behind the peritoneum, and it's found between the left colic flexure or the splenic flexure, extends to the left iliac fossa, and there it continues as sigmoid colon. So the peritoneum covers this descending colon anteriorly and laterally, just like the ascending colon. They are covered by peritoneum anteriorly and laterally, and this peritoneum binds them to the posterior abdominal wall. So they are secondarily retroperitoneal parts of the large intestine, the ascending and descending colon. Descending colon thereby after that it usually descends and pass anterior to the lateral border of the left kidney, and just like the ascending colon, it has paracolic gutter onto its left. This is on the left side of the descending colon, between it and the abdominal wall on the left. So you can appreciate the right paracolic gutter. This is the ascending colon, right paracolic gutter, descending colon, left paracolic gutter. Why do you need to understand these spaces? These spaces in the abdomen, there's usually communication. Below the diaphragm, you have the subphrenic spaces on the right and on the left. Below the liver, you have subhepatic space. Then you have right and left paracolic gutters parallel to the colon. Then you have left inframesocolic space and right inframesocolic space. So if you have infection below the diaphragm, it can spread to all these spaces. If you have infection in the pelvis, it can spread above the diaphragm. You can have pus in the pelvis spreading to above the diaphragm, pus in the pelvis spreading to below the liver. So these arrows are just showing you how all these regions communicate. Remember, this is your lesser sac. Go back to the lecture on the peritoneum. This is the lesser sac below the liver, okay? And this is your greater sac. So there is that communication of fluid, right paracolic gutter, left paracolic, pelvic cavity, subhepatic, and subphrenic. So fluid, infection, tumor can spread to all these potential spaces. So next we discuss the sigmoid colon. It's usually S-shaped. You can see it here. It's variable in length, 40 centimeters, and links the descending colon to the rectum. It extends from the iliac fossa on the left to S3 segment. Then it's actually where the tinea coli terminate, and that termination is 15 centimeters from the anus, and it indicates the rectosigmoid junction. So the rectosigmoid junction is 15 centimeters from the anus, and it is the location where the tinea coli terminate. The sigmoid colon has a very long mesentery, therefore it makes it very mobile, especially on its medial aspect. On its medial part, it has a very long mesentery that makes it very mobile. So the termination of the tinea coli, we've said, indicates the rectosigmoid junction. The sigmoid mesocolon has an inverted V-shaped root. The root is inverted V-shaped and usually extends along the external iliac vessels, then inferior to the bifurcation of common iliac to the anterior aspect of the sacrum. Okay? The sigmoid colon has omental appendices. These omental appendices usually disappear when the sigmoid mesentery terminates. The tinea coli also disappear as the longitudinal muscle actually broadens to form the rectum at the rectosigmoid junction. So the descending and sigmoid colon are supplied by branches of inferior mesenteric artery, mainly the left colic and sigmoidal arteries that join the marginal artery of Drummond. The transition at the left colic flexure shows you that there is a transition between superior mesenteric and inferior mesenteric. From the left colic flexure, if you go proximally, they're supplied by superior mesenteric artery, it's a transverse colon. And if you go distally from the left colic flexure is a descending colon, the blood supply is by inferior mesenteric. And that just shows you anything before the left colic flexure are midgut derivatives, and anything downwards from the left colic flexure are the hindgut derivatives, because inferior mesenteric artery is from hindgut and superior is from midgut. So you find that out from your embryology. So these left colic and sigmoidal arteries, they run parallel with left colic and sigmoidal veins that drain into inferior mesenteric vein. From there, blood goes to splenic vein, and splenic vein joins superior mesenteric vein to form the portal vein that enters the liver. Lymphatic drainage of descending and sigmoid colon is through epicolic and paracolic lymph nodes that go to intermediate colic lymph nodes, which are along the left colic, and afterwards into the lymph nodes around the inferior mesenteric artery. Lymph from the left colic flexure may also drain into superior mesenteric lymph nodes. So this just shows you the left colic and sigmoidal branches of inferior mesenteric joining the marginal artery of Drummond, and this shows you the two potential watershed areas because you have communication or anastomosis. Like here, there is an anastomosis between superior mesenteric and inferior mesenteric branches. It's a junction between hindgut, foregut and midgut. Sorry, midgut and hindgut, because midgut is supplied by superior mesenteric, hindgut by inferior mesenteric. So where there's connection of the two, that's a watershed area that's prone potential site of ischemia. And then this lower portion where you have inferior mesenteric communicating with hypogastric arteries, that's another watershed area. This just shows you the watershed areas again, the splenic flexure. There is the right colon may also be vulnerable, especially the antimesenteric border, and the rectosigmoid junction is also vulnerable to ischemia because of connection with the proximal arteries. This shows you the veins, the lymph nodes, I mean. So the ileocolic nodes, okay, left colic nodes before you get to inferior mesenteric lymph nodes around the origin of inferior mesenteric artery origin. Innervation is mainly by sympathetic and parasympathetic. Sympathetic are from lumbar part of the spinal cord to the sympathetic trunk. Then the lumbar splanchnic nerves they use the superior mesenteric plexus, okay, around the superior mesenteric artery to get to the descending and sigmoid colon. So lumbar sympathetic trunk to lumbar splanchnic nerve via superior mesenteric plexus and inferior mesenteric artery plexuses. Parasympathetic follow the pelvic splanchnic nerve via inferior hypogastric plexuses and nerves to get to the descending colon and the sigmoid colon. So towards the middle of the sigmoid colon, you can get pain, that visceral pain that will pass retrogradely, and then these fibers will be carry reflex information via parasympathetic fibers. So pain retrogradely is carried through sympathetic fibers, while reflex information will be carried via parasympathetic fibers. So away from the middle part of the sigmoid colon, this is towards, as you go towards the middle part of the sigmoid colon, pain is by sympathetic and reflex information carried by parasympathetic fibers. But as you move away from the middle part of the sigmoid colon, the visceral afferents usually follow the parasympathetic fibers retrogradely to the sensory ganglia of the spinal nerves. So the visceral afferents will follow parasympathetic. Towards the middle part, the visceral afferents were following sympathetic fibers. But away from the middle of the sigmoid colon, visceral afferents are following parasympathetic. Both is retrogradely. Okay. So what is sigmoid volvulus? The sigmoid colon has a very long mesentery, therefore making the sigmoid colon very mobile. So it can twist on the root of the mesentery, leading to, you can see the contraction at the base of the mesosigmoid, leading to torsion and obstruction of bowel. Then bowel can be strangulated. This part distends, and if you don't operate to loosen it up, it can undergo gangrene. So because of the long mesentery, there is torsion at the base, leading to obstruction and strangulation of bowel. That's sigmoid volvulus. So the anatomy of the rectum and anal canal was covered under pelvic visceral lecture. So you can just look for the pelvic visceral lecture and find out the anatomy of the rectum and anal canal, which are also part of the GIT. Thank you very much.